Now let's switch over to brain tumors that we usually see in adults. We'll talk about metastases to the brain, glioblastomas, meningiomas, oligodendrogliomas, pituitary adenomas, CNS lymphomas, and schwannomas. Brain metastases are most commonly due to hematogenous spread from the lung, but colon, kidney, breast, and skin, particularly melanoma, are all seen. Metastases from other organs are the most common type of CNS tumor in adults. Metastases primarily occur at the gray-white junction where there is acute angle vascular branching. They additionally are more likely to be seen at the watershed areas of the cerebral vessels, possibly due to decreased rate of blood flow in these areas. On imaging, brain metastases generally appear as one or more sharply demarcated tumors at the gray-white junction. Histologic, immunohistologic, and molecular features of metastatic tumors aid in identifying the primary origin. One or maybe two mets to the brain may benefit from surgical resection or gamma knife radiosurgery. Multiple metastases are treated with whole brain radiation. Whole brain radiation is not curative, but can slow progression of the disease. Glioblastoma, also known as GBM, is a grade 4 astrocytoma. Glioblastoma is the most common malignant brain tumor in adults and generally occurs between ages 50 to 60. Unfortunately, the prognosis of patients with glioblastoma tends to be poor. Recall that astrocytomas are a type of glioma and have an appearance most similar to astrocytes, but their cell of origin is currently unknown. Glioblastomas are distinguished from grade 3 astrocytomas by the presence of necrosis or endothelial proliferation histologically. Median survival for patients with glioblastoma is around 1 year. About 10% of glioblastomas carry a mutation in the isocitrate dehydrogenase gene, or IDH. Prognosis is improved in these patients, with survival ranging from 5 to 7 years. Glioblastomas are generally found in the cerebral hemispheres. Because they are highly invasive, they are sometimes found spreading to the opposite hemisphere, such as through the corpus callosum. This results in a butterfly-like appearance, hence why they are sometimes called butterfly gliomas. On imaging, they generally present as infiltrative of surrounding structures and can be ring-enhancing. This is especially pronounced when there is visible central necrosis seen on imaging. Here are key features of glioblastomas on histopathology. On the left, we see necrosis with surrounding nuclear pseudopalisading. Pseudopalisading tumor cells are hard to reach with chemotherapy and are in a hypoxic environment. The hypoxia stimulates VEGF production, which stimulates angiogenesis. On the right, we see the resulting microvascular proliferation in an area of necrosis. The microvascular proliferation is disorganized compared to normal vessels, with multiple layers of endothelial cells, multiple lumens, and the lack of tight endothelial junctions. In glioblastoma and grade 3 astrocytomas, the neoplastic cells demonstrate marked mitotic activity. Moving on now to meningiomas, which are the most common benign brain tumor in adults, and are thankfully overall more common than glioblastoma as well. They are usually an incidental finding on neuroimaging obtained for some other clinical indication, but sometimes they can grow large enough to cause symptoms for mass effect. Meningiomas are more common in patients with neurofibromatosis type 2 and occur along with schwannomas in those patients. Meningiomas are usually grade 1 and do not invade the brain parenchyma and are located extraaxially. Meningiomas can be located throughout the cerebrum, wherever there is dura, including in the orbitofrontal region, along the cerebellar tentorium, and along the falx cerebri. On imaging, meningiomas are well circumscribed and homogeneous. There should be a visible connection between the tumor and the dura, as either a tail or a broad base. The histopathology of meningiomas always reminds me of Van Gogh's Starry Night. Histopathology of meningiomas shows epithelioid or spindled cells in the shape of whorls. Collagenization and calcification of the whorls results in formation of psammoma bodies. You may remember that in addition to meningiomas, psammoma bodies can also be seen in papillary thyroid carcinoma, serous cystadenocarcinoma of the ovary, and mesothelioma. Oligodendrogliomas are a slow-growing type of glioma that most commonly occur in patients between 30 to 40 years old. They are WHO grade 2 or 3. Survival is around 10 to 20 years if grade 2, and around 5 to 10 years if there is progression to grade 3. Grade 3 is known as an anaplastic oligodendroglioma. Like in glioblastoma, mutations in IDH predict a better outcome. 1p19q codeletions also predict a better outcome. This is when there is an unbalanced translocation of the first chromosome with the 19th chromosome, resulting in deletion of the short arm of chromosome 1 and the long arm of chromosome 19. Oligodendrogliomas have a predilection for invading the cortex, so they are more likely to initially present with seizures. They are most commonly seen in the frontal lobe. Imaging will often show calcification. Histopathology of oligodendrogliomas shows two particularly characteristic features. Because of slide preparation artifact, oligodendroglioma cells have a paranuclear halo, also known as a fried egg appearance, on histology. They also often have a branching chicken wire pattern of capillaries. Pituitary adenomas are the most common tumor in the sellar or suprasellar region. Like meningiomas, small pituitary adenomas are also very common and frequently are asymptomatic and incidentally found. However, they can become symptomatic if they are hormonally active or if they have mass effect on structures like the optic chiasm or the pituitary stalk. Pituitary adenomas are classified by size, with tumors less than 1 centimeter being called microadenomas and tumors greater than 1 centimeter called macroadenomas. This is clinically relevant because microadenomas are more likely to be symptomatic from being hormonally active. They most commonly produce prolactin or ACTH, but can potentially produce all of the anterior pituitary hormones, including TSH and growth hormone. Macroadenomas rarely produce hormones, but because of their size, are more likely to present with visual changes like bitemporal hemianopia or headaches. Primary CNS lymphoma is a tumor made up of B lymphocytes. Although in general, lymphoma from B cells or T cells usually is found in the lymph nodes, primary CNS lymphoma is a type of lymphoma that can be localized just in the brain or spinal cord. It's seen in two populations, in the elderly and in the immunosuppressed, such as patients who have HIV/AIDS. In the immunosuppressed patients, it's particularly associated with infection with Epstein-Barr virus, the same virus that causes mononucleosis. CNS lymphoma is usually found in periventricular regions in the cerebrum, but can occur with multiple foci. On imaging, CNS lymphoma appears homogeneously enhancing in the immunocompetents, but ring enhancing in immunosuppressed patients due to central necrosis. CNS lymphoma can show response to steroids and methotrexate. On pathology, diffuse large B cells are seen, staining for CD20. CD20 is an important marker for identifying B cell lymphoma. We'll end with schwannomas. Schwannomas are a peripheral nerve sheath tumor occurring in the vestibulocochlear nerve. It can interfere with normal cranial nerve 8 function and cause sensorineural hearing loss and tinnitus. Vertigo is less common. Bilateral schwannomas in combination with meningiomas are particularly suggestive of neurofibromatosis type 2. Because of the location where the 8th cranial nerve leaves the lower pons, schwannomas grow in the space between the cerebellum and the pons, called the cerebellopontine angle. They don't invade the CNS, so they appear well circumscribed on imaging. On histopathology, schwannomas appear as a biphasic tumor with dense Antoni A and loose Antoni B regions. The nuclear palisading on the left is referred to as Verroque bodies.